I've got a lot of slides. I realized last night in the hotel room that, so I'm going to be sort of sliding right through some of them, and I apologize for that. But first, about a year and a half ago, we've been trying to do things around health equity for a long time and not having as much success as we hoped. And we thought, well, what is a unique area that we could make a real contribution to within the state health department? And it sort of came down and we thought, well, maybe health literacy was an area we should explore more deeply. And so part of that, a couple of good things happened. One was, you see Janelle Lamont's name up there and Charity Kreider along with me. Charity was a newer staff, hadn't been there, but had a passion for health literacy. And Janelle was a fellow at that point from Directors of Health Promotion Education. They have a minority internship program and had expanded it to also include those already with their master's degree or soon to be doctors. And so we were fortunate to have Janelle come and be with us for a year, and it gave us the health literacy position that we hadn't had in the past. And unfortunately, that fellowship is now ended, but we did hire her into our oral health program, so she's still with us. Okay, basically, what we wanted to do when we looked at this is first take a look at health literacy and what it meant to public health, and then some of the barriers in Minnesota, as well as what role we should take as a state agency, and looking again at but I'll skip past that. And then it's interesting, these definitions just came up in the last session, but one of the things, the definition you see over and over again is this one here attributed to the Institute of Medicine, and basically talking about individuals and empowering them really to make appropriate decisions regarding their health. And that's a good definition, but it doesn't completely work for public health, because, especially when you're at the state level, because the people we work with aren't often individuals, but more working with systems and decision makers and power brokers and trying to shift at that level. So the WHO did make a statement that in 2008, that they thought health literacy should be expanded in scope to include social determinants of health, and we very much agree with that. And again, the definition you just saw, the one that we really like, or I like anyways, is Friedman's definition, where it looks at individuals and groups, and really the focus is to make public health decisions that benefit the community. The one change I might make there is, instead of saying the community, I might say their community. Because I think it's also about empowering individuals and groups within a community to make changes and to know how to work with decision makers to affect the environment that they live in and their community lives in. In terms of barriers to health literacy, these are the ones that you find in the literature. And one I want to point out is I won't go through all the bullets, but the second one from the bottom, not the second one, where is it? I'm sorry, the third bullet, the lack of cultural appropriateness of health information. That's one actually we realize increasingly we're having to deal with, because in Minnesota there's a large immigrant population. In the last couple of decades there's been a lot of African, East African, West African, as well as before that preceded by the Hmong population from Laos and Vietnam. And to give you an example, the diabetes prevention program, which we're working very hard to try and make that available statewide. But on some of the clinics, like we had a conference last month, called Many Faces, which is something our diabetes program started 20 years ago, the root of that. And it's mainly the community health providers attend that, and it's a focus on, they largely serve the uninsured in Minnesota or those who are on Medicaid. And in terms of trying to offer the diabetes prevention program to the Somali population, for example, one group that had hired and trained Somalis to conduct the workshop, and these were very capable and alert people, but working with their own population, they still had trouble. Because, for instance, the first session, there's a half-hour data gathering. It took 5 hours to complete. And there's 16 one-hour sessions throughout the year. And in doing that, they had to go long on all the sessions, and that quickly affected attendance in the sessions. And so they tried again where they modified it, and they didn't get a lot of weight loss at the end of it. Or increase in physical activity. So they modified it, tried to make it more graphic, and extended the session, made the sessions a little shorter actually, and tried to switch the order around a little bit to try and get them doing hands-on things right away. And the results they were discouraged by, because they weren't any better. In fact, in terms of weight loss, they didn't lose any weight. But they did, which I was surprised, they showed a slide in their presentation when I saw it where they had actually reduced BMI, which I thought was an important outcome. But they didn't talk about that. But anyway, so there's a lot, and their conclusion was that the diabetes prevention program doesn't work for Somalis, which, to me, it begs for a good study, where you really try to incorporate some health literacy principles into sort of redesigning or modifying the curriculum and testing it with a larger sample to see what happens. Now, just to talk about the barriers in Minnesota, in 2030, the numbers of Minnesotans over 65 will have doubled from what it is today to about 20% of the population. And being someone who's not that far away from joining that group, I must say, I'm not looking forward to it. But there's also a lot of people in rural Minnesota that maybe didn't go that far in terms of the educational system, who are older, who, is one target group that we need to look at. Another thing is the schools have become increasingly segregated over the last couple of decades. And there's some different things happening. One is the rapid growth, rapidly changing demographic, where many of the neighborhoods in Minneapolis and St. Paul have become largely one race or another, and the schools reflect that. But the other thing that's happening is the charter schools, which started in Minnesota, which get a lot of good press. I mean, and it's really a very sincere effort to reach out to students that may otherwise drop out of school and aren't doing very well. But the evaluations of those programs that are done carefully generally show that take similar students either in a public school or in a charter school, and generally they do worse. They do better in the public schools. And the fact is the charter schools drain resources from the public schools that they need. And so you wind up with two programs that are sort of in some ways not receiving the full funding that they need. The other thing with charter schools is a lot of times they're just in a building somewhere and they may not have a cafeteria or a field to have recess in. The other thing that's happened, well, just with charter schools too, as the communities of color have moved out into the inner ring suburbs, there are more charter schools popping up out there, and they're largely white, and that parents are pulling their kids out of the regular school and putting them into charter schools. So what was a policy that had good intent in some ways is backfiring to that degree, though I'm sure I'd get a lot of debate on that. But there's also a school choice option in Minnesota, which allows students to go to a different school in another district if there's space available, and often there is. And what's happened, my own kids went to Roseville High School, which is a mostly white community, but does have African Americans and Hispanics. But what's happened by the choice issue, a lot of the African Americans have chosen, rather than to go to school at Roseville High School, they've chosen to go to St. Paul, which is right next door. And a lot of the white kids in St. Paul chose to go to Roseville High School, and the result was an 11% increase in the white population at the Roseville High School. So it's just, that's happening all over the state. Roseville's just an example because I know it well. But so basically the schools are increasingly less integrated. And in terms of health literacy, that relates to a lot of exposure issues and the things you come to know and see as models or examples or things to pursue. Your world becomes much narrower. There's also a home ownership gap in Minnesota. Populations of color, generally about 38-39%, own their own homes. In the white non-Hispanic population, it's 76%. It's double. That's a 38% gap compared to a 25% gap nationally. Okay, so some of the barriers to health literacy, to go a little further with that, is that roughly 25% of the foreign-born of any race lack a high school degree. I mean, this is once they're 25 or so, or a GED degree, compared to 6% who were born in Minnesota or somewhere in the United States. And then of all the black children in the state, 35% have a foreign-born parent, at least one, and they may be foreign-born themselves. The children from 19 and under, 1 in 6 is a child of an immigrant. And for children 0 to 4, it's 1 in 5. So everyone thinks of Minnesota as this white state up north, and it's changing rapidly. I mean, it's granted that's happening all over the country. Minnesota's a little slower, but it is something that we're probably is not as seasoned in working through the kinds of policy issues that have come up that other states have worked with for years. We have a lot to learn. I think one other thing I was just mentioned, the high school graduation rate. In 2012, students of color had a 50% on-time graduation rate, getting through high school in 4 years. For the white population, it's 84%. Okay, the good thing there, though, is that back in 2003, those numbers were 43% and 79%. So it's actually, the graduation has gone up 14% for students of color. Okay, this shows the insurance records. I mean, who's on insurance or isn't on insurance across the different racial or ethnic groups. See, American Indians, that's 23%, but a lot of those are actually going to Indian Health Service. There are 12 reservations in Minnesota. Oh my gosh, 5 minutes. Okay. Anyway, so skip it. But the interesting thing is that with the black and foreign-born, the difference between 24% and 12%. Okay. Also, we have to look at the impact of the Affordable Care Act. We think that's going to cut in half the number who are uninsured, which is going to change where they might be seeking medical care. Okay. Skip through these slides. Basically, one of the things we did is we created a map, a low health literacy composite based on the literature. We obviously couldn't survey the state, but to test health literacy. But what we did was found those things that are associated with it, and we used. It's very simple compared to what you saw the RAND Institute has produced. But we used basically we look for by census tract 25% those tracts that were 25% less than 25% white, more than 15%. Where English wasn't spoken very well, more than 20% foreign-born, more than 15% living in poverty, and more than 23% 65 or older, and less than 75% having completed anything more than high school. And made a scale out of that, and that's where you can see the inset for Minneapolis and St. Paul, where it's much higher than the rest of the state. But if you look at just age and high school education, then you can light up the rest of the state too, or much of it. Now, in terms of the cost aspect of it, one thing I just want to mention quickly, there was a study done by in one of the clinics, a pilot study, where they were working with an East African community. And what they did, they trained community health workers to do home visits to the patients that were East African, and work with them to explain the American medical system and how you don't always go to the emergency room. There's also primary care, urgent care, etc. And just that intervention alone cut the emergency room visits in half and reduced their per patient cost by 40%, over 40%. And I think a lot of it was attributed to the nurse line that was people were used, and they had bilingual people on the nurse line and were able to handle a lot of their issues. So they came up. Okay, so we needed to put together a workshop to kind of get our staff up to speed, and this is what we did that in March, and our goal was to create a public health workforce at MDH that was fluent in health literacy principles and best practices. I'm going to have to skip through some of this, but these were goals and our learning objectives that we defined through our work. And then we took advantage of two tools that are available through CDC, the online health literacy training course, and we had all the participants in the workshop complete that training online before coming to the workshop to really kind of get. And for a lot of people, that was probably their first real initiation or consideration of what health literacy was all about. And there was also Appendix D in the a guide to creating easy-to-understand materials as a checklist for doing an overview of your print materials and improving it. And with those two tools, we had them do a homework assignment where they picked something from their area and developed, tested it for its health literacy aspects and tried to tweak it, and brought that with them to the workshop. In our workshop, getting past this. This is the beginning of the day. I talked about health literacy and the different definitions and some of our frustrations with it and how do we approach it. Then we had Mark Ozier, who was a professor at the University of Minnesota in communications, and he talked to us about behavioral theory and how we might use it to target or design and evaluate health messages. The next part, Jennifer Dillaha, who's here today. And fortunately for us, I think Charity went to a workshop or something and met you at that point and kept talking about how we had to get you up to Minnesota. And so we did, and she really inspired us by what you could do with a fairly modest budget, the kinds of change that could take place, and it really meant a lot to us and helped. And then she even stayed extra time and met with our supervisors and helped us move forward. Okay, this is a video we showed over lunch. It was called Say It Visually. We actually did this for Stan Shanling, who's head of our Heart and Stroke group, led this development of this and got another 20 states involved. They all chipped in $1,000 or something and produced this, and it's available online. They're simple messages. They'll, as I said, take 20 seconds, and anyone can download them and use them, and there's also an app if you want to put it on your smartphone. But we didn't use any of the 7 steps, I have to say that. That's kind of when you don't have much of a budget, you can't go through. Oh, jeez, I'm at 0. Okay, let me just skip on. We did the workshop. There were 85 people there, and this is the evaluation overall. The one thing that people liked it in general, the thing they wanted more time with, though, was to have more practice and feedback with the training that we did. And in terms of the future, one of the things I want to say, in terms of an opportunity we'll have with health literacy in the future, we want to set up a course where it's just a standard course available in the health department for new staff and staff that need to be brought up to speed. Also, there's going to be we have to do a report on health equity for the legislature this upcoming session. And what can we do to help address that? And hopefully we'll be able to put a strong component for health literacy in that. And I'm sorry I didn't have more time, but hopefully you have the slides to go over. And please contact us if any of you have questions going forward. I think I'm in the right spot. Okay.